Alrighty, good afternoon, everyone, and happy October 1st. I hope you all are well. Thank you so much for joining today. So why don't we go ahead and get started? I did want to introduce Dr. Lisa Costello joining us here on the call today. She's from WVU Medicine Children's, and she's working for the West Virginia DHHR during the COVID response. We also have Dr. Lauren Spadafora joining us as well, who is the influenza outbreak epidemiologist for the state. So we're really excited to have you both here on the call today and giving us the wonderful didactic, which we're really excited for. As always, please chat in your name and where you're tuning in from if you'd like to receive CME credit. And after the end of today's session, we will be conducting a very brief poll just to gauge some feedback from you all as well. So without further ado, why don't we just jump right in? Drs. Costello and Spadafora, I'll share my screen and share the PowerPoint. Just let me know when you'd like me to advance the slides for you.
Sounds great. Thanks, Mitra. It's good to see everyone again. I have been working with the Bureau for Public Health and DHHR since March. In my day job, I'm a pediatric hospitalist at WVU Medicine here in Morgantown. And I really want to say thank you to Dr. Lauren Spadafora. One of the things I've learned working so closely with DHHR, there are so many people behind the scenes that produce the data that we frequently see on the websites or in the news stories, and the information that's driving our public health actions, and really work behind the scenes to keep our communities safe. And Dr. Spadafora is certainly one of those, and so really grateful for her. These slides are ones that she put together that I adapted, so I really want to say thank you to her for sharing these and being with us. We wanted to talk about influenza and COVID. As Mitra said, it's already October 1st, hard to believe that, but we are right at the brink of influenza season, and there's been a lot of discussion about trying to prevent a twindemic, having a flu epidemic on top of our COVID-19 pandemic. And so we thought it would be helpful to share some information about what we're going to face this fall. You can go ahead and advance. So we have no disclosures. You can keep advancing. And so we'll get into talking about the influenza and COVID-19. Go ahead and advance. Thank you. So here, we've already been dealing with this unprecedented pandemic, and now as we're going into influenza season, these viruses are going to be circulating. And here is a slide that talks about respiratory illnesses, and there's seasonality that we see in these viruses, which many of us on this call know. So we have seasonal influenza, where there's a range of 29 to 58 million illnesses a year, up to 17,000 to 100,000 deaths per year. As a pediatrician, RSV, anecdotally, I can say last year was a really rough RSV season for us. We, as our Children's Hospital Morgantown, we went on diversion. We were running out of high flow tubing. We just, at least anecdotally, at the past few years, I thought last year was a pretty significant RSV season. And you can see here that, 57,000 children less than 5 years of age get hospitalized a year, but it also impacts older adults as well, particularly those in nursing home settings. And then you can see other respiratory viruses such as parainfluenza, adenovirus, and then typical coronaviruses that cause illness. This is talking about not SARS-CoV-2, given that's a new virus that we've been dealing with. And so we can see that these viruses can be asymptomatic to even fatal, where we can see deaths. And really, I think as we progress into this fall season, a lot of us are going to be faced with this challenges, what virus is it? And as we've been focusing on COVID-19, many of the symptoms are the same, and we're going to get into that. And I think that's why we wanted to bring this to you this year, this early on, because I already have been receiving questions about this, and I'm sure Dr. Spadafora has as well, in regards to, which one is it? What are these symptoms, since there's a great deal of overlap? Go ahead and advance. So here, we're talking about kind of these emerging viral illnesses. The ones that I just talked about are pretty well known to us who work in primary care and the hospital setting. And so these are kind of, these emerging viral respiratory illnesses that we have seen over time in the past. So in 2003, we experienced SARS, which was also caused by a novel coronavirus. And then, that had a pretty high fatality rate, which was certainly concerning. And then in spring of 2009, that's when we had the influenza pandemic with the novel H1N1, typically known as swine flu, given that it originated in pigs. And then in 2012, we saw MERS, or the Middle Eastern Respiratory Syndrome, that was also caused by a novel coronavirus. And then in 2014, we saw an epidemic of acute flaccid myelitis. As a pediatrician, we were certainly concerned and worried about that disease. And that would mostly impact children developing this sudden limb weakness after having a respiratory illness. And it's thought to be associated with enterovirus. And, many of these viruses have started from transmission from animals to human. And these events can then spread, which is what we're going to see in the next slide if you want to go ahead and advance when we're talking about COVID. So this is a timeline just put together of what we've seen with COVID. So we still haven't even been dealing with SARS-CoV-2 or COVID-19 for an entire year. So we saw this present in Wuhan, China in the end of 2019, where we had Chinese health official announce this cluster of acute respiratory illnesses. And then just a few weeks later, we saw that in the United States, and we have continued to battle this as that's the whole purpose of this echo. And so as you can see here, just the spread as we've continued to deal with it. In March is when our state in West Virginia started doing in-house COVID testing. Since that time, we've seen an expansion of testing. Many of you on this echo may be doing some form of testing in your offices. It was also in March where this was then categorized as a pandemic. We had our stay-at-home order by the governor in late March, but then in May, we started opening back up. And of recent, we've just seen more openings of schools. And I know in my county of Mon County, today was the first day of in-person participation for many of the students, as they have been participating virtually since that time. And so as of today, we've seen over 15,000 cases in West Virginia. There's been over 7 million cases in the United States, over 34 million cases worldwide. And then we did just recently surpass the grim 1 million death marker worldwide, with over 200,000 of those deaths occurring here in the United States. Go ahead and advance. So in case anybody needed a refresher, this is what SARS-CoV-2 is. So it's again named for those crown-like spikes, as in the family of coronaviruses. We still are learning a lot about it. It's an RNA virus that has mutated and continues to mutate. And as I discussed before, there are some of those other coronaviruses that we've seen make that transition from animals to humans. And that's what we believe is what happened here, although there is still some controversy in regards to what exact animal it did originate from. But this has been obviously an ongoing tricky pandemic that we've had to battle in regards to symptoms and the long incubation period that we've been seeing with SARS-CoV-2. And so, we've learned more and more about this virus, and we continue to learn more. And I think certainly as we progress into the fall and winter months, we're going to continue to learn more, particularly when it comes to talking about co-infection with these other respiratory illnesses. Go ahead and advance. So this is just a reminder of influenza. We've been talking so much about coronaviruses. Now it's time to talk a little bit about other viruses. out there. So this is a single-stranded RNA virus within the orthomyxovirus family, and they're classified into types A through D. A and B are what we see infect humans, and as you can see, there's the different seasonal circulating viruses that we see. And it's really important in regards to influenza viruses when we're talking about the changes that the viruses experience when we talk about antigenic drift and antigenic shift. And this is why we see a different influenza vaccine every year, so that researchers and through surveillance, which we're going to talk about, we can identify the most common virus strains in our communities to then hopefully protect us through the seasonal influenza vaccine. Go ahead and advance. So now when we're getting into, influenza and COVID-19, what's the difference and really what are the similarities? And I think what's going to be certainly challenging for all of us out there practicing primary care is what is the difference? The signs and symptoms really do overlap a significant amount. And they also cause many of the same complications. And so as we're seeing both of these viruses circulate in our communities, I think it's going to be challenging to say, one or the other. It seems like at this time, the one thing that does tend to be more unique to COVID-19 is that loss of taste and that loss of smell. Also, in the more complication range, we've seen blood clots in veins, arteries, pulmonary embolism. We've seen multiple different blood clots. And then also what we talked about our last echo, where we actually presented a case of the multi-system inflammatory syndrome in children. That still seems to be more particular to after a COVID-19 infection. But I think the other symptoms that, are pretty common this time of year, particularly when you also throw in complications of allergies with congestion, fatigue, sore throat, cough, fever, shortness of breath, myalgia, headache, and those GI symptoms are definitely symptoms that we see in many of those viruses we talked about in the beginning. Go ahead and advance. So when we talk about influenza, really we're talking about influenza-like illness. We know, like with COVID, flu can be mild, but it can also be more severe. So many a times individuals could recover at home, which we still see even with coronavirus, most individuals having milder symptoms that they're able to recover at home. And when it comes to influenza, we don't always test to confirm the disease. And so usually when we're talking about doing influenza surveillance from a public health standpoint, we really track this syndrome known as influenza-like illness. And the definition is a fever with a cough and or a sore throat without a known cause for that illness other than influenza. So basically, they don't have strep throat. And so in long-term care facilities, which we've been talking a lot about, and I think in the future we'll talk even more about in these echo sessions, is using the McGreer criteria, fever, and at least 3 of the following sub-criteria that you see there. So chills, headaches or eye pains, myalgias, malaise, loss of appetite, sore throat, or new or increased cough. And so many of those respiratory viruses that we talked about in the beginning can also cause infections needing an influenza-like illness. And, we see that also with SARS-CoV-2. So I think it's going to be even more of a challenge on our public health officials this year to really be doing influenza surveillance plus COVID-19 surveillance paired with those other respiratory illnesses that we see. Go ahead and advance. So when we're talking about transmission, we also see that there are similarities in how they're spread. And so in Australia, there's actually already been some thoughts that the flu season was a little less severe, given that many of the infection control strategies being deployed can also protect against influenza. And so we know that there is this person-to-person spread with respiratory droplets produced by coughing and sneezing, particularly when you're in that close contact. We're thinking maybe if you come into contact with those surfaces in the environmental setting and then you touch your face or your eyes, your mouth, that you could potentially contract that. But did want to emphasize, we still do not see any foodborne transmission. Early on in this pandemic, there was a concern that, could this be potentially transmitted through food transmission, and that's not been founded at this time, at least. And then with COVID-19, I think what we've started to hear more and more about are these like super spreading, events where we're seeing more and more spread in certain situations. So there's been instances, say it like a choir practice, where then from that there are multiple cases. There was an incidence in Washington State where over 32 confirmed cases and 20 probable cases were among attendees of a choir practice. Go ahead and advance, Mitra, thanks. So here's another side-by-side comparison about seasonal influenza and SARS-CoV-2. So the incubation period for influenza, from what we know, is shorter than SARS-CoV-2. So with influenza, we're talking 1 to 4 days. With SARS-CoV-2, 2 to 14 days. That's where much of that public health guidance in regards to quarantine come from. In both diseases, unfortunately, there is that asymptomatic or pre-symptomatic period, which has really, I think, been one of the challenging parts of this pandemic, because really individuals are spreading the disease or spreading the virus before they have symptoms. So for flu, it tends to be 1 day before you start having symptoms. With SARS-CoV-2, we think it's around 2 days. The contagious period for flu after onset, 7 days, where with SARS-CoV-2, what we've seen in viral cultures is more 10 days. And then when we're talking about percent cases of asymptomatic, it could be up to 85% with influenza. With SARS-CoV-2, we've seen a broad range of 10 to even 70% being asymptomatic. You can see the R0 is higher with SARS-CoV-2. And then we're still working on the case fatality rate for COVID-19, but there is agreement that COVID-19 has a higher case fatality rate than what we see with seasonal influenza. And so I think, this is going to be one of the questions that I certainly think we talk about or we get from patients that I've been getting already about what is the difference between these two and how long are you symptomatic. I think just the public in general is more aware of these type of terms because we've had so much more discussion given the pandemic. Go ahead and advance the next slide. So here's just kind of a little bit of a Venn diagram of who's at higher risk for influenza or COVID-19. We are starting to see more cases in children of COVID-19, but in regards to really causing severe illness, that's what we're talking about here, this severe influenza or severe COVID-19. And when we're talking about flu, it does tend to target children less than 2 years of age. Last year, there were 188 deaths from influenza in regards to children. And then in individuals who have heart disease or neurodevelopmental conditions, as you can see there, a list of other high risk conditions, or individuals who are on aspirin, they have an increased risk for severe influenza. When it talks about COVID-19, what we think are people who smoke, and then also those variety of underlying conditions that you see listed there. And then really when we're talking about who's at risk for severe disease from both, it's certainly our elderly population. So those greater than 65 years of age who also have comorbid conditions such as obesity, serious heart disease, COPD, kidney disease, diabetes, sickle cell, immunocompromised, other lung conditions such as asthma or cystic fibrosis. And we're still continuing to learn more about how severe disease would be in pregnancy. Go ahead to the next slide. So now we're going to talk a little bit about surveillance and how, we'll talk more right now about what are some individual factors that we're seeing increased risk. And we certainly have been seeing this disproportionately impact racial and ethnic minority groups. There was a pretty sobering, I think I mentioned this the last echo, 75% of children with severe illness or death are from either Hispanic, Latino, or African American communities. But also we see a higher risk for both COVID and influenza in rural communities, which impact us, many on this practice in rural communities, but individuals who experience homelessness, pregnant breastfeeding women, individuals with disabilities or developmental behavioral disorders. So I think when we're going to talk about some prevention things, this is really important that we're talking to individuals in these groups, certainly about making sure they're washing their hands, wearing a mask, staying physically distant when they can, and then also when it comes to influenza, getting their flu vaccine. Go ahead and advance. So now we'll talk about surveillance a little bit, and this is where I'll also ask for the help of Dr. Spadafora. Go ahead and advance. So here when we're talking about how do we talked about ELE or influenza-like illness, and so this is basically just what the CDC is doing, where we're identifying new influenza viruses that impacts vaccine selection. It also helps healthcare providers like us make treatment decisions. It helps us identify high-risk persons, how well we're doing with our prevention strategies. And so then we continue to make changes to our vaccine and antiviral repertoire as we move forward. Go ahead and advance things. So I did want to highlight the difference between influenza and COVID surveillance because they aren't the same. And so we have established influenza surveillance. So this is not based on a case definition or case investigation. And there are various indicators compiled to monitor timing and severity of that influenza season. So in the system, excuse me, we don't capture every single influenza illness because not everyone goes to seek healthcare. Not everyone gets confirmatory testing. We still will many a time see empiric therapy being used, and we use a Sentinel surveillance model. When it comes to COVID-19 surveillance, this has been based on case definitions and case investigation. We also have seen and heard a lot about contact tracing to try to prevent further transmission. And we know that we're trying to get more timely and prioritize confirmatory testing in certain individuals. And then we have various indicators compiled to determine what counties are experiencing heightened activity and why. Go ahead and advance to the next slide. This, I put in more so Mitra could send these out. These are just some of the influenza and COVID-19 dashboards that you could follow to determine. I know that we're from all different areas of the state on this echo. So this will allow you, excuse me, to more so determine what are you seeing in your particular area when it comes to COVID and flu. Go ahead and advance. So this is just talking about what is reportable. So I think for many of us, our labs take care of it. So all COVID-19 test results get immediately recorded by electronic lab reporting. If some of your clinics are starting to do rapid testing, that's something that we're seeing more and more in regards to getting onboarded to electronic lab reporting so that those results can be immediately reported. When it comes to flu, there's more of a weekly aggregate count that gets submitted to Dr. Spadafora and her team. And so from us, from a provider standpoint, if we do see a patient experience a death, if it's an influenza-associated pediatric death, that has to be reported within 1 week. A COVID-associated death has to be reported immediately. And then also, it's an immediate report if you have a child who you think could be having the multisystem inflammatory syndrome in children, or MIS-C. And so here you can also see where we have influenza outbreaks and infections being reported to the local health department as well. Go ahead and go to the next slide. I put this slide in here because I thought that this is just kind of showing where we've seen West Virginia respiratory outbreaks over the past couple of years. And so you can see the different color coding in regards to influenza-like illness, and then obviously COVID-19. And I didn't have, obviously we're just into October now, but don't have September data completely in there quite yet or analyzed. But here you can see certainly we started to see a spike upward after we opened back up for business per se. And we started to see more and more reopenings. And you can see the breakdown there between COVID-19 in the healthcare setting versus not in the healthcare setting. Go ahead to the next slide. So here I'll turn it over to Dr. Spadafora to let her describe what influenza Sentinel providers are, and if anybody on this call, maybe some of you already are, if you're not, and you would potentially want to become one, she can share information for that.
Good afternoon, everyone. I hope you can hear me. So yes, my name is Lauren Spadafora. I'm the influenza epidemiologist at the State Health Department. I've been in this role since July 2018, so I have 2 influenza seasons under my belt. The Influenza Sentinel Provider Program is in conjunction with the CDC. The CDC has a surveillance system called ILI-NET. And what happens here is primary health care providers of any specialty, it's traditionally been outpatient providers. We've seen urgent cares, family care, internal medicine providers be a part of this program. But basically what happens is we recruit and enroll these providers every year. We have about 50 or 60 participants every year across the state. What they do is every week they track the number of visits they receive for influenza-like illness. So this is the symptom-based definition, not having to do with any flu testing or anything like that. But they keep track of these visits they have every week for influenza-like illness. They go online and they report the aggregate counts of those visits by certain age groups. I think it's like 0 to 4, 5 to 24, 25 to 44, going up to 65 and older. And they also report their number of patient visits for that week. And what we can do is we can generate an indicator that is % of healthcare visits for influenza-like illness. And we don't have this on a slide, but it's an indicator I have online and on reports that I send out during the flu season. But we have this indicator, every week we track that %, and during influenza season, it creates this peak. And what can happen is that we can compare like the magnitude of that peak and how wide that peak is to see what that flu season is looking like relative to other seasons, the timing of it, the severity of it. This is this program, we've had this for a long time, I think at least 10 years. I could be wrong, but we're currently in the recruitment season. We're currently starting to report. This is the first week of report. If you're interested, you can let me know. I believe my contact information is there. Again, it's just for most facilities or providers, it's online every week, providing some numbers, submitting that report. Some incentives we have is that we have CDC funded vaccine. We can provide some doses that we typically have said to administer those to your staff. So we provide you an amount per how large your staff is. So you can administer that to any adult, as long as you don't charge for that dose, and as long as you log that into our immunization registry. We have traditionally provided free shipping and confirmatory testing for respiratory specimens to the state laboratory. That is, kind of, I'm trying to think of the right turn of phrase. We're kind of working on that right now. COVID-19 obviously has created some issues as far as laboratory testing this year. So we're working on that, getting that information out to our Sentinel providers on how we want to proceed. And then of course, for my participants and my state partners, I provide a weekly report on state and regional flu activity, which helps healthcare providers understand if flu is actively circulating in their communities and whether they might need to consider empiric therapies, need to consider flu testing, etc. So if you have any questions, I think my email will be at the end of this slide, and I'll hand it back off to Dr. Costello.
Thanks so much, Dr. Spadafora. And yeah, I think that many of you on the call probably are, maybe already Sentinel providers, but if not, we will see here in just a little bit her contact information. So you can go ahead and advance where we'll finish up our slide deck here and then certainly get into questions. So now we'll just talk a little bit about prevention and control. Dr. Spadafora mentioned a little bit, I didn't go much into testing here. I still think we're seeing some variety in regards to flu testing, versus testing for flu and influenza and for RSV. There's been talks of a biofire also including COVID-19. I think that we're still, in the beginning of this pandemic, we were testing for both flu, RSV, and sore throat. I think that's really going to come down to you seeing the patient and what symptoms they're having to determine what additional testing you would get. I think that also is going to determine or help be determined based upon what you're seeing in your community. I have a colleague who's an OBGYN in Alaska. She was exposed to COVID-19. Her 2.5-year-old son started having a fever. So she went and got him tested for COVID-19. They didn't test for anything else. He continued to have fever. He ended up having influenza A. And so it wasn't diagnosed until, he continued to have fever and then was able to get started. This was before they were even able to have flu vaccines in their communities. So go ahead and advance and we'll talk just a little bit about those prevention strategies. So getting vaccinated, taking those everyday preventive actions to stop the flu, and then using anti-viral drugs. So this is a great document that many of you could consider putting up even in your clinics. And then if you go ahead and advance, many of the preventative actions that we've been recommending to stop the spread of COVID-19 also help with other respiratory illnesses. So as I said, in Australia, we've seen or at least heard reports of a not as severe influenza season, likely perhaps because of the infection control strategies to prevent the spread of COVID-19. So washing hands, avoiding close contact, that physical distancing, wearing a cloth covering in the public, covering your coughs and sneezes, cleaning and disinfecting, and then making sure we're having symptom monitoring and then staying home when sick. Go ahead and advance. So when it comes to flu vaccination, we do still have flu vaccines, and we're actually seeing a higher distribution of flu vaccines in this year. The CDC even ramped up their efforts in regards to and working with the manufacturers to distribute even more influenza vaccine. And it is still recommended to get flu vaccination during COVID-19. Some tips I put in here for practices would be to screen patients for symptoms of COVID before the facility, limiting how much they're having points of contact in the facility, and then wearing cloth face coverings, good hygiene. Go ahead and advance. And then also just making sure that we're reducing our waiting areas. I think as we enter into the cold season, that might be more challenging, or see back to what we were seeing in the early spring where individuals were having people wait in their cars. We have been seeing more and more drive-through flu vaccine clinics on a weekly health officer call this week. We had some encouraging news, at least anecdotally. We don't have any numbers that many individuals were going to these testing events and getting their flu shot in addition to getting COVID-19. We're seeing a variety of models. Some offer both on the same day. We've seen some keep the testing lanes for some days and then have flu vaccine on other days. So certainly reach out to your local health department and determine if that's a place where individuals could get flu vaccine. But these are just some other clinic logistics that have been talking about making sure if you are delivering the vaccine in a clinic setting, keeping that physical distance the best that you can, and then using electronic means through telehealth. Obviously, when you're talking about delivering vaccines, they need to be in person, and that's why I think we've seen more and more drive-through clinics. But those are all the slides that I had. If you go ahead and advance and leave Dr. Spatafora's contact information, that's mine, and then Dr. Spatafora, in case anyone would want to reach out and become a Sentinel provider. But I would, as we transition to questions, like to ask the first question, because I actually got a media inquiry this morning, and I'm planning to call back after this session. The media inquiry was that some private practice doctors' offices were not going to offer the flu vaccine for a variety of reasons, citing COVID-19 as one of those concerns. I had not heard that in the area I practice, Morgantown. I had reached out to some other clinics and I hadn't heard that. I definitely think the whole testing, and I definitely think that there will perhaps be maybe a change in testing and individuals will direct them to the testing tents. But I wanted to see if anybody on the meeting have heard that, or if your practice itself is not offering flu vaccine, or if you've heard that in your community. That will at least help me in my media inquiry when I get off this echo.
Thank you so much to both of you, Dr. Costello and Spatafora. That was a very timely topic. So yeah, does anyone have any comments to Dr. Costello's first question? Feel free to use the chat as well.
Just here in Franklin, I mean, we're trying hard to get the message out to get everyone vaccinated. We're, I mean, we always work hard at it, but I think we're working harder than usual this year. Although we are getting questions about, well, there's not anything about that COVID in this vaccine, is there? So we're having to reassure people that a flu vaccine is a flu vaccine.
Good, and I think someone typed in the chat box that they've not heard that at all from the Primary Care Association. They're providing influenza vaccine in their community, and then there's other individuals starting to provide flu shots. Yeah, I have not talked to the reporter yet, but you know, I think that I certainly don't want the message to get out that people can't get their flu vaccine, you know, because I think, as Dr. Rexroad pointed out, we've been trying to increase our efforts to encourage individuals to get a flu vaccine so that we don't have this twindemic where we're talking about a flu epidemic on top of our COVID-19 pandemic. So I think there's been a lot of efforts at the state, as well as I know the Center for Rural Health Development has an influenza campaign that they kicked off in working with our Division of Immunization Services. They have a lot of great resources for practices that you can request to hang up in your offices and share on social media sites, including videos and things like that, talking about the importance of influenza. But thank you all for that. That's not something that I had heard either, but nothing like having a forum with providers from around the state to ask the question to. So.
Thank you very much. And we did get a chat earlier asking about the distribution and administration when it's available. And so Dr. Spatafora and Costello are participating on the state task force and developing a plan in accordance with the CDC guidelines. So keep the chats coming through with the questions. We did have one quick question as well as we wait for more coming in through the chat here. So someone was wondering if flu shots can also help protect someone from COVID-19 as well.
So, and I would certainly welcome anybody else. I don't know if I didn't see Dr. Hodder today, but you know, I think there was I believe Dr. Moffitt, and I'd have to like look at the study in regards to children, when we thought children weren't being impacted as much. Was there some in regards to, you know, other vaccinations, even hearing like the MMR? I don't know if Lauren, if you've heard anything particular. I think as Dr. Rexroad pointed out, you know, we have to tell everyone that this is an influenza vaccine. The COVID vaccine is coming. As Dr. Spadafora says, our state is very much engaged. I think you'll be hearing more about that coming from the governor as early as tomorrow in regards to what the state has been doing to plan in regards to a potential COVID-19 vaccine. There's a lot of unknowns right now when it comes to a COVID-19 vaccine, but the state is, as other states are, taking an active approach to prepare when that comes. But in the meantime, using this time to really focus on influenza vaccine. But Lauren, have you heard anything about potential protection for COVID from influenza?
I mean, I shook my head vigorously. I mean, those are two distinct viruses. So, you know, antigenically, I don't believe there will be, you know, any cross protection. I mean, I guess I can't really comment on anything about, you know, if you get your flu shot, you know, that you know, could get some protection as far as like in the context of a co-infection, you know, like, you know, if you have, you know, better outcomes, if you have both viruses and, you know, you've gotten your flu shot. I hope that makes sense. But yeah, I've not heard anything about, you know, protection either way.
Thank you both. So we got a few questions here in the chat. So one of them is asking, is there any understanding of why minority children account for the majority of pediatric deaths?
So I think there's ongoing studies in this. It's well studied that, you know, racism and healthcare disparities do lead to multiple poor health outcomes in children. The American Academy of Pediatrics is one of the first major organizations that actually has issued guidance on racism and health disparities as being a child health issue. I think that a lot of times it has to do with multifactorial issues. So perhaps lower socioeconomic status, more apprehension to seek medical care. So they're getting delayed care. So when they are presenting, it's later, less access to healthcare resources. So less access to testing, you know, potential comorbidities. And so I think that those are some of the areas being looked at in regards to why is this population so disproportionately impacted. But we've seen that in other cases, you know, children of color or individuals, Hispanic, Latino, tend to get, say, you know, different treatment of pain or prescription of antibiotics. So this is not only being seen in COVID-19. We do see this, unfortunately, across the board in multiple child health disease processes. And so I think as we continue to analyze that data more, we'll learn more. But those are some of the initial thoughts that I have in regards to why we're seeing that be disproportionately impact. Also, I think that the spread perhaps more being in closer proximity, whether that's, you know, urban living or something of that nature. But those are some of the initial things that I've heard.
Excellent, thank you. We got a chat in from Gordon Smith saying that they're currently expanding their program to monitor COVID-19 in wastewater, and they also hope to be able to monitor influenza in the same wastewater sample once the manufacturer develops a combined testing plate. Thank you so much for sharing that. So the next question we got in was, is there utility for biofire or similar testing to help rule in other viral etiology to allow return to work or school?
I personally haven't seen any sort of like, you know, official federal or state algorithm that, you know, speaks to that. However, I mean, I think multiplex testing in general is going to be a huge help helping healthcare providers make clinical and public health management decisions.
Yeah, I would agree with that. I mean, I think as we've seen this evolve in the beginning of this pandemic in the inpatient setting, we were testing everyone BioFire and COVID testing when they presented to the hospital. I will say that just amongst my pediatric group, there's been discussion about using BioFire less, and making sure that we use it in the correct clinical scenario. But then COVID happened, and then we were like, oh, let's figure out what is really causing the ailment. And I think what we're going to need to learn more about early in this pandemic, we did think there was co-infection in regards to flu and COVID. And I think as we get into this fall, winter respiratory season where now COVID is more apparent in our communities, it's going to be, I think, I don't know if interesting is the right word, but for me, I think it is going to be interesting to see how much of a co-infection do we see in regards to COVID and these other respiratory illnesses. And plus, I think part of my challenges is where we've seen people test positive for COVID for such a long period of time. And really, what is that clinical significance? We've seen individual tests for two months positive and never have symptoms whatsoever. So it's going to, I think, be a little bit of a challenge to see what is really our co-infection as we move into the respiratory season.
Thank you very much. And thank you to Dee for adding that reference from the CDC racial equity page that they have there. So definitely check out the chat with that resource. Any resources we get in, I'll also include in the recap email. So kind of going off of that question, the next one was asking if labs are offering multiplex testing for flu and COVID simultaneously.
Yes, so there's, as far as I've heard, there's going to be multiplex assays available. The CDC has developed one that is under emergency use authorization, and they are distributing that to all state public health laboratories. So our West Virginia State Public Health Laboratory, otherwise known as the Office of Laboratory Services, or OLS, they will have that capability this season. I'm still in communication with them about when that will become available and, how many of our specimens that come in for COVID-19 diagnostic testing will be tested on that platform. And I do have a number of clinical laboratory partners across the state, and I've been hearing that certain partners have been adapting or have been adopting multiplex assays. I've heard, the BioFire, and I think I also believe, but I'm not entirely sure, I've heard that the Cepheid Gene Expert is moving completely to a flu COVID-19 multiplex format, but I don't know that 100% sure at this time.
Yeah, and I also have just heard of individuals sometimes testing for COVID first and then that getting reflexed to a flu test. Or vice versa, doing flu RSV and then reflexing to COVID. And so, because as the supply chain continues to be, although it's better than it was, it still continues to be a concern. I've heard some anecdotal reports of individuals having challenges getting swabs or testing supplies as well. So at least early in the pandemic, that's why we just decided to test everyone, because it was more of a supply conservation effort. And that's why we just kind of did that blanketed approach. But I think we're still seeing what individuals are planning to do and just see what comes out onto the market. I think obviously if the BioFire includes COVID-19, I think you'll probably see, at least in pediatric practices, probably where we were using it before the pandemic in a high amount, we'll probably see it continue to be used. Obviously, the concern is that's a pretty significant cost, and COVID-19, at least in the past bills, is continued to be covered, although we've heard some reports of people getting bills. I think it's going to be hard when the COVID-19 test is in a larger multiplex panel, because I don't know how the payment for that works out. I mean, a BioFire is multiple hundred of dollars, and even in some cases thousands of dollars. So depending upon the insurance carrier. So I think time's going to tell a little bit in regards to how broad spread those can be offered, and then what the payment of those tests are going to look like.
Thank you both. And thank you, Emma, for chatting in that some community health centers will be performing rapid COVID and flu testing simultaneously as well. So kind of going off of that question, we had a question asking if you could sort of explain what multiplex and biofire are, and if those are like trade names for particular tests.
So yeah, a multiplex assay is one where you provide a single specimen and it tests for a variety of disease targets. You know, in the case of a respiratory multiplex panel, you could have a single specimen test for flu, coronaviruses, human metapneumovirus, adenovirus, et cetera. And what companies have started doing is adding SARS-CoV-2 into that mix. The BioFire is indeed a trade name. Some other names you might hear is Cepheid and GeneMart. I think can't think of any others at the moment.
Excellent, thank you. So we had another question asking, how do you see pharmacies that provide flu vaccines fitting into the plan to reduce risk for a twindemic this year?
So I can start with this, and then Dr. Spadafora chime in as well. So as Dr. Spadafora says, we both serve on the state vaccine planning and distribution group. We have multiple pharmacists represented on that group. There's been a medical advisory group formed that also has multiple pharmacists. I think the commercial pharmacies receive flu vaccines many a times earlier than clinics. There's been publicity of commercial pharmacies having the flu shot available as early as September, where I think at least many of the primary care offices didn't receive it until later, still waiting on a robust supply. So pharmacies, I think, will certainly play a role in regards to providing influenza vaccine. And then also moving forward, when there is a COVID vaccine, they're certainly very much engaged in the discussion and integrated into that plan to be able for more widespread immunization efforts. So they're certainly already doing it, and at least from talking to some pharmacists that work in the commercial, they say that they've been giving a great deal of flu shots. So that I think is encouraging. I don't know if all the publicity or individuals being concerned about COVID and the flu as well, and potentially leading to more time off work, if that's leading to an increase in flu vaccine uptake. I think time's going to tell, but certainly we have pharmacies engaged in multiple regards in regards to flu vaccine. I think you'll be also seeing more testing be available at pharmacies, and I think that there's ongoing discussions with different commercial pharmacies in regards to testing opportunities as well. So there was a question here about optimal flu vaccine timing. I'm so excited because I get to say one of my favorite hashtags, hashtag flu before boo. So I always recommend trying to get the flu vaccine before Halloween. But as you can see, it is, we can see influenza into March or April. So you really should be recommending the flu vaccine even through that period of time. It takes about 2 weeks for your body to develop immunity towards the strains in the flu vaccine. And so the goal is to get people immunized before we're starting to see widespread virus in the community. And so that was why we thought this was a pretty timely talk, because Lauren could speak more. I spoke of my colleague friend who had a case in Alaska, but I'm not sure what we've been seeing. I have heard anecdotally some flu cases, but as she said, we're just starting to report this week. So I think we'll start to learn more, but the goal is really to get it as soon as possible. I think September, October is a really good time. But I always emphasize, even if you didn't get it in that period, it's really important to still get immunized in November, December, January, and February, because we can see flu into March or April. And again, if you get one strain, you could have flu A, but you obviously still could potentially get flu B. And last season, we did see that. I had patients who they had flu A early in the season, and then we saw a spike of flu B later.
Yeah, I'll just also add, at least with my sample size of 2, I've typically seen flu activity increase around the holiday season, though it is certainly possible to get a flu positive right now. I mean, it's also possible to, if you use a rapid test, if prevalence is sporadic, it's low, you could get a false positive with a rapid influenza test. So we're kind of just in a, what do you call it, an interim period. We could have flu, but there's other viruses circulating around. I know parainfluenza has caused us a bit of problems, showing a little bit of heightened dial-I activity, but no flu detections, and that's been tricky to sort out. The other thing I was going to add is, my first flu season, going into the 2019 season, we saw some, very ugly flu cases into April, and that was due to the H3N2 strain. It's sort of like more, there's substrains. I mean, the virus is increasingly complex. There's just probably thousands of varieties of the virus going out there, and we condense it into these certain groups. But what happened was a sort of new substrain of H3N2 emerged, and it didn't match the vaccine. So in that particular year, we even saw some outbreaks and nasty cases of flu going into April.
Thank you both, yeah. And we got a chat in from Dr. Leonard sharing that they had a positive rapid COVID and flu 1 week ago, and the PCR was COVID positive and flu negative. Thank you for sharing that. We got another question asking, so what about potential interference with SARS-2 vaccine when it arrives? They're not expecting it to really be available for the general public until after the flu season.
Yeah, great question. I think, there's ongoing studies, the finalists, if you will, are those who have been able to progress through the clinical trial phases. There's been more and more information released in regards to protocol and what are different factors being considered. I think, honestly, time's going to tell. We're still waiting to hear what the data shows in regards to the various vaccines that are going to be available for COVID. I do agree. I think we are thinking there's going to be a phased approach in regards to the vaccine rollout and administration. And so I think that it is correct in the statement. I think we're going to see probably more general public vaccine for COVID distribution probably towards the end or after flu season. But I think we just need to wait and see what the studies show. They're just not, there's been some preliminary data released, but again, as we're getting into those phase 3 trials, that's where we're gonna, I think, learn more and see what potential, interaction there may be. Again, I think, as Dr. Spadafora said, these are 2 different viruses, so but again, I think just time's going to tell on that one.
Absolutely. Thank you so much. So we've come to the final minute here of our session. I did want to leave some time for the poll here, but I wanted to ask you if there was any, Dr. Costello, I think Dr. Spadafora had to head out, but I wanted to ask you if there was any final thoughts or comments you wanted to share with the group.
Nope, just everyone stay safe, get your flu shot, and thanks again to the ECHO team